Hi, hello. I'm continuing my online residency program, and this time I'm going to complete the module about outcomes and indicators pressure injuries. Okay, let's begin. Introduction. The nurse receives report on their patient who has a history of rib and bilateral ankle fractures from a recent fall. The patient also has a history of mild Alzheimer's disease and is currently receiving intermittent enteral tube feedings via NGT and is able to use a urinal bottle with assistance. Urinal bottle. Know the following assessment details before answering the test questions. Findings: authorize 95 on 2-liter oxygen via nasal cannula, 114/58, 82 beats per minute, 18 breaths per minute, 97.8 Fahrenheit, that's 37.1 degrees Celsius. 60 kilograms, BMI is 18.4 kilogram meter squared. Okay, that's fine. 18 BMI is okay. Let's check. Underweight. He is underweight because the normal BMI is 18.5. So the patient is underweight. The nurse determines that their patient is at high risk for pressure injuries. Which of the following contributes to the patient's risk? Low body mass, middle age, sedentary lifestyle, caffeine use. Sedentary lifestyle, definitely. Okay. Next, during daily assessment, the nurse notes a red and intact and unblanchable area over the patient's sacral area. The nurse should implement one of the following. Document a stage 2 pressure injury, stage 2 non-blanchable area, intact and non-blanchable area. Non-blanch means you cannot hold it up. Non-blanch. Blanchable, non-blanchable. Okay. So non-blanchable versus blanchable. This is stage 1, stage 2, stage 3, stage 4. Non-blanchable. This one, non-blanchable area. Okay, blanchable, non-blanchable. Okay, stage 2. There's stage 1 is non-blanching. So this is wrong. Sacral area is not back. Sacral. Oh yeah. But it's lower back. It's lower back. It's not upper back. Sacral area. No, you don't massage. Yes, Euro position. Okay, next question 3 of 5. The healthcare team for the patient has confirmed stage 1 pressure injury. In addition to regular repositioning, which of the following interventions would also be appropriate to prevent further ulceration? Ensure 0.1 milliliter KCl free fluid intake. Obtain a pressure distributing mattress. Cover the area with dry gauze. The question is, how will you prevent further ulceration aside from repositioning? Cover the area with dry gauze and paper tape. Begin oral antibiotic therapy to prevent infection. This is to prevent further ulceration. To prevent further ulceration, you should, yeah, obtain a pressure redistributing mattress. Pressure redistributing mattress help prevent further ulceration. Pressure redistribution mattress. All right, these are those ones. Okay, this is to prevent infection, not ulceration. Prevent infection. Fluid intake is not enough. Okay, the nurse is assessing the patient with an intact and maroon colored area of skin discoloration on the back of the patient's left heel. Okay, maroon colored stage 2. Intact maroon color. Deep tissue pressure injury. Maroon color stage 2. Right? Ay, maroon colored wound stage. Pressure ulcer. Yes. Stage 1. Wow. Yeah. All right. Maroon colored deep tissue pressure injury. It's still intact, so stage 2. The nurse will plan to provide care to the patient's intact maroon colored pressure injury of the left heel. What is the most common? What is the most effective implementation measure the nurse should initiate? Yes. No, you've already evaluated it. No. 60%. Okay, good job. Now let's move on to the lecture.
This program is designed to provide an overview of pressure injuries, signs, symptoms, prevention, and interventions related to the care of the person at risk for or diagnosed with a pressure injury. The program will support clinical professionals in applying the best available evidence in practice as it relates to pressure injuries. The objectives for this course are for the student to be able to list risk factors for pressure injuries, recognize signs and staging of pressure injuries, identify preventive measures for pressure injuries in the areas of skin care, mobility, positioning, and nutrition, define various treatment modalities and interventions for pressure injuries. Click on each item for more information. Value-based purchasing describes care purchased by an insurance company from an organization based on the quality outcome measures for that organization. Outcome measures evaluate the results of overall care, for example, mortality, readmission rates, or hospital-acquired infection, but do not evaluate whether specific interventions were performed. Pressure injury as localized damage to the skin and underlying soft tissue, usually over a bony prominence or related to a medical or other device. The injury can present as intact skin or as an open ulcer and may be painful. The injury occurs as a result of intense and/or prolonged pressure or pressure in combination with shear. Up to 23% of patients in long-term and rehabilitation facilities have pressure injuries. Up to 41% of patients in ICU have pressure injuries. Up to 90% of pressure injuries can be healed using preventive measures and proper wound care. Malnutrition was the most significant risk factor associated with pressure injuries, as identified by ICD-10 codes. The lower back, including the sacral and coccygeal areas, is the most common location for a pressure injury, 47% of all pressure injuries. Patients with one or more pressure injuries had increased mortality, 9.1% versus 1.8%. Pressure injuries are also known as pressure ulcers, bed sores, and decubitus ulcers. Any person of any age, including neonates, is susceptible to developing pressure injuries. Any pressure or shear force that prevents capillary blood flow from bringing oxygen and nutrients to an area may lead to a pressure injury. Many factors can predispose a patient to pressure injuries. Any factor that affects nutrition, circulation, or mobility, including increased pain from comorbidities like cancer, will increase risk. Specific risk factors include acute illness, smoking, incontinence, low body mass, immobility, poor nutrition, advanced age, sepsis, previous DVT, cancer, cognitive impairment, diabetes, renal failure, vascular disease, increased friction or shear, sensory impairment or loss, hypotension or vasopressor medication use. There are 6 classifications of pressure injuries, 4 of which are stages that are differentiated by the depth or thickness of the wound, as shown in this chart. A Stage 1 pressure injury is a localized area of redness, usually over a bony prominence. The skin usually does not blanch on exam. Stage 1 pressure injuries may be difficult to detect on darker pigmented skin. A Stage 2 pressure injury is considered a partial thickness wound. It usually presents as a shallow, open wound that can be shiny or dry. Sometimes a blister may still be intact with serous or serosanguinous fluid. Skin is usually pink or red around the wound bed. A Stage 3 pressure injury is a full-thickness wound with loss of tissue. These wounds may go deep. Fat or adipose tissue may be visible. However, bone, tendon, and muscle are not visible. Tunneling may be present, and the tissue loss is obvious. A Stage 4 wound is considered full thickness with skin loss. Stage 4 pressure injuries usually go to the bone and expose tendon, muscle, or bone. These wounds may have slough, eschar, and tunneling. Frequently, they include the joint capsule, which puts the patient at risk for developing osteomyelitis or osteitis. In Stages 3 and 4, slough and eschar may be present in the wound, but if they prevent the assessment of tissue loss or depth of the wound, then the wound should be classified as an unstageable pressure injury until the slough and eschar have been removed and the wound properly assessed. Two categories of pressure injuries are not assigned to a specific stage. Unstageable pressure injuries are full-thickness wounds with tissue loss. Sloughing and eschar make it difficult to determine the true depth of the wound. The slough and eschar must be removed before a stage can be determined. These pressure injuries will fall into stage 3 or 4 after removal of the dead tissues. The second type of pressure injury not assigned to a specific stage is a deep tissue pressure injury that is not yet ulcerated. It may appear as discolored skin or as a blood-filled blister. These injuries are caused by significant pressure and/or shear forces at the bone-muscle connections, also known as the bone-muscle interface. As in the case of unstageable pressure injuries, the depth of the wound cannot be assessed. These deep tissue injuries may be more difficult to locate and assess on patients with darker skin. Pressure injuries are generally diagnosed using assessment techniques to identify size, color, induration, and other details about the injury. Diagnostic tests are rarely used, and usually only for the purposes of diagnosing complications of pressure injuries or investigating potential causes of slow-healing wounds. Radiologic imaging, tissue biopsies, or bone biopsies may be used in these situations to acquire more in-depth information about the wound and to guide more advanced interventions. Drag the statements below into the boxes to indicate whether they are true or false.
Risk for pressure injury increases if mobility and nutrition decrease. Any pressure that prevents oxygen and nutrients from reaching tissues may lead to a pressure injury. Any pressure injury with eschar is automatically categorized as stage 4. Eschar false. Okay. Any pressure injury at eschar cannot be staged until the eschar is removed. Yeah, you have to remove the eschar. Okay, got it. Over 50% of pressure injuries will not heal completely. I'm not sure. Correct. Over 90% of pressure injuries will heal by secondary intention or non-surgical closure if proper care is administered. Osteomyelitis is a potential complication of pressure injuries. Potential inflammation of the muscles of the bones. Maybe true. Deep tissue injuries are more easily assessed in patients with dark skin. False. It's more difficult. Yep.
Careful skin care is one of the primary preventions for pressure injuries. Of course, good skin care begins with a good baseline assessment, followed by regular ongoing assessments. Healthy, moisturized, clean, dry skin has a greater ability to withstand pressure and shearing forces. Avoid extremes in temperature and use barrier products and attentive incontinence care to keep skin as dry and clean as possible. Consider using prophylactic dressings over bony prominences or other areas prone to pressure injury. Preventing skin and tissue injuries associated with the use of medical devices. Most of these skin complications may be prevented by daily assessment and adjustment of the medical devices to properly fit the patient. Although not all preventive measures for pressure injuries are listed in this course, most fall under categories listed in this chart and the one on the following page. Each patient's presentation and needs should be taken into account when planning care to prevent pressure injuries. Naturally, assessment should come first with the use of a validated pressure injury risk tool, such as the Braden scale. Interventions should focus on relieving or reducing pressure, managing external irritations such as bowel or bladder waste, and promoting excellent nutrition and hydration, discussed on the next page. Nutrition is one of the most important but often overlooked aspects of both pressure injury prevention and treatment. As always, perform an assessment and risk profile to determine necessary interventions. Consulting a registered dietitian or nutritionist who has experience with patients at risk for pressure injuries will provide guidance for monitoring and improving the patient's nutritional status. At-risk patients may require extra encouragement and/or assistance at mealtimes to ensure that adequate nutritional and fluid requirements are met. Nutrition and hydration are essential parts of keeping skin and underlying tissues healthy and free from injury, as well as providing the building blocks for healing. If the Braden scale is used to determine the patient's risk for pressure injuries, consider implementing the recommendations associated with a particular score as listed in this chart. The 30-degree lateral position recommended here avoids a more severe angle that puts increased pressure on the skin overlying the trochanter of the hip. Once a patient is diagnosed with a pressure injury, healthcare providers should advocate for and perform the measures in this chart as appropriate for each patient, in addition to continuing all preventive measures previously listed in this course, especially those listed on the Interventions by Braden score page. If available, consider consulting specialized wound care services for patients diagnosed with pressure injuries. Each wound should receive care specific to its stage, exudate amount, need for debridement, and overall patient presentation or needs. Any sharp or surgical debridement must be performed by trained and licensed healthcare professionals only. After debridement, ensure that active bleeding has ceased prior to applying a new dressing. Identify the correct stage of pressure injury. Meticulous skin care, repositioning, wound care, and adequate nutrition are important for proper wound healing. Proper rest, increased protein in the diet, not smoking, and keeping the wound clean and dry all contribute to prevention and treatment of pressure injuries.
Pressure injuries, top recommendations. Goal to highlight interventions most likely to improve outcomes. For patients at risk for or diagnosed with high profile medical conditions. Prevention, skin assessment and care. Assess skin within 8 hours of admission, then daily at minimum. Identify high risk patients using a tool such as Braden scale. Keep skin clean, dry, and moisturized, using pH-balanced skin cleansers when necessary. Avoid massage over bony prominences, hot water, and heating pads. Consider barrier products to prevent skin from excessive moisture. Consider prophylactic sacral and heel dressings for high-risk patients. Create and utilize individualized plans for incontinent patients that include and skin cleansing the skin promptly after each episode for incontinence. Pressure and positioning. Use pressure reducing or redistributing devices in both the OR and the clinical units. Reposition chair-bound patients every hour and encourage every 15-minute small weight lifts. Small weight shifts if the patient is able. Keep head of bed less than 30 degrees and less contraindicated feeding tube. Follow best practices regarding use of medical devices and reducing risk of tissue injury. Nutrition and hydration. Use a malnutrition screening tool for at-risk hospitalized patients. Consult a registered dietitian or nutritionist for patients at high risk for nutritional deficits. Follow individualized nutrition and hydration plans to maintain calorie moisture intake. Assess size, color, and duration under visual details. Identify presence of eschar and slough. Monitor for elevated temperature, accident, foul odor, increased pain, or signs symptoms of cellulitis. Usually diagnosed using assessment finding above. Classify stage pressure injury according to current NPIAP guidelines. Imaging, X-ray, MRI, bone scans to confirm suspected osteomyelitis. Tissue biopsy may be used to investigate non-healing wounds for malignancy or bacterial invasion. Treatment, practice excellent hand hygiene at all times and aseptic technique during dressing changes or acute care environment. Monitor and address pain levels. Use primary post-surgical wounds or secondary non-surgical wounds dressing appropriate for the type and staging of the injury. Treat infectious wound processes with systemic antimicrobials if indicated. Reduce risk of ongoing wound development by practicing preventative measures listed above. Consider supplementing protein or amino acids. Consult professional wound care services for extensive or non-healing wounds. Consider debridement, grafting, skin, muscle flaps, direct closure, or other constructive measures as indicated. Points to remember: identify the correct stage of pressure injury, proper rest, increase protein in diet, not smoking, keeping the wound clean and dry all contribute to prevention treatment of pressure injuries. Meticulous skincare, positioning, wound care, and adequate nutrition are important for proper wound healing. Stage 1, non-blanchable erythema redness. Stage 2, partial thickness, ulcer intact or non-intact, serum filled, shallow red pink wound bed, no slough. Full thickness skin color with or without undermining and or tunneling. Sub-Q fat visible, no bone and muscle visible. Full thickness. Stage 4, full thickness tissue loss. Full unstageable full thickness skin or tissue loss that obscured by slough or eschar necrotic tissues will fit into either stage 3 or 4 once necrosis is removed. Deep tissue pressure injury, intact or non-intact. Discolored skin, usually deep red maroon. Oh, it's called deep tissue pressure injury. Or purple in color and or blood-filled blister, typically from shearing or pressure. Skin may be firm, mushy, or exhibit fluctuance, wave-like motion on palpation. Discoloration may appear differently in darkly pigmented skin. Okay, yes. Now let's take post test. Have to have 84 out of 5 questions. So the nurse receives a report on their patient who had a history of rib and bilateral ankle fractures from a recent fall. The patient also has a history of mild Alzheimer's disease and is currently receiving intermittent enteral tube feedings via NGT and is able, which means that her bed should be greater than 30 degrees and is able to use a urinal bottle with assistance. Note the following assessment details before answering test questions. Findings: autosats 95%, and 2-liter oxygen via nasal cannula, 114 per over 58, 82, 18, 97.8. Okay, start. The nurse determines that their patient is at high risk for pressure injuries. Which of the following contributes to the patient's risk? Low body mass, middle age, sedentary lifestyle, caffeine use, sedentary lifestyle. During daily assessment, the nurse notes a resident intact and non-blanchable area over the patient's sacral area. The nurse should implement one of the following: reddened, intact, non-blanchable, reddened, intact, non-blanchable, reddened, intact, non-blanchable, bony preeminence, no, serum filled blister is 2, reddened, intact, non-blanchable, reposition the patient to relieve pressure. Okay, the healthcare team of the patient has confirmed the stage 1 pressure injury in addition to regular positioning. Which of the following? 1 ml of chemical free fluid intake, obtain pressure, cover with dry gauze and paper tape. Begin an oral antibiotic therapy to prevent further ulceration. Okay, so for it to prevent further ulceration, begin oral antibiotic therapy. Maroon color deep tissue pressure injury. Maroon color intact. Off. Don't elevate the heel from the surface of the bed to ensure just remove using specific heel suspension device. Oh no. Low body mass is the answer. And obtain pressure. I answered this earlier. Obtain pressure distribution mattress. Okay. Retake. Yeah. Low body mass. Reposition. Pressure distribution mattress. Deep tissue pressure injury. Offload. Alrighty, post this one. My guys, so fast. I hope all the modules are this fast. Okay, that's it. Thank you so much. This is the end of this module.